You'll remember that croup is an infection of the upper airway that's oftentimes caused by a virus called the parainfluenza virus. But how do we make the diagnosis? The majority of the time, the diagnosis is clinical. That means we don't need a bunch of lab tests or x-rays to figure out what's going on, but instead we use the history and physical to deduce the answer. By history, the patient or their family will say that there's been a cough going on. This is oftentimes the most prominent symptoms. They may describe the cough as barky. There may be other sick people around, particularly other people with upper respiratory infections like colds or coughs. And they may have recently had, or they may still have, symptoms of an upper respiratory infection or a cold. By subjective physical exam, the cough is often evident. There may be, although not always, a low-grade fever. Stridor can be heard, and that may be very subtle stridor that needs a stethoscope in order to bring it out, or it could be audible stridor that you could hear from across the room. And that stridor is usually on inspiration. And if things are bad enough, there may be respiratory distress. And that can take the form of using accessory muscles to breathe or a low oxygenation status. Sometimes the diagnosis isn't exactly clear, or we might be considering other things. There is a differential, as many problems with the upper airway can lead to similar symptoms. Oftentimes, the patient will just have a common cold. That can sometimes have a bad cough associated with it. More serious problems could come in the form of abscesses. The things that are most commonly looked for are abscesses behind the throat, or retropharyngeal abscess, or abscesses next to the tonsils, or peritonsillar abscess. If the child choked and aspirated on a foreign body, that could certainly cause similar symptoms. Or if the child has gastroesophageal reflux, the inflammation due to this can cause adjacent inflammation of the airways. Sometimes, in order to pin down the diagnosis better, an X-ray is performed. This may be an X-ray of the neck, in order to look at the airway within the neck, or it might include an X-ray of the chest as well, or it might include the chest if problems with the lungs are suspected. So let's take a look at what you might see on one of these X-rays. On the left side of the screen over here is a normal view of somebody's neck, and on the right side of the screen is a patient who has croup. So let's look at some of the differences. Let's take a look at the airway. I'll outline it here in blue. And let's take a look at this area right here. The top of the trachea, which is a relatively round tube, as it goes into the larynx, or the voice box, has these little bumps, and those bumps are part of your vocal cords. And it should be a relatively sharp transition right here. You should see nice shoulders. When you see those, there's probably not a lot of inflammation in the wall that's blurring things out. Let's take a look on the other side. I'm going to outline the trachea again in blue. Notice the difference here? Again, let's focus on this top part of the trachea here. Here we're looking at a very sharp transition from the larynx to the trachea. And some people liken this to the steeple of a church. When you see that, it implies that the tissues are swollen up, and those nice shoulders that we would have had have gotten swollen and are no longer present. Let's take a look at the lateral view. Again, normal is going to be on the left, and croup is going to be on the right. So let's take a look at these airways. This dark structure is the patient's larynx or voice box. Very easily seen. Down a little bit further, it transitions to the trachea. Similar structures are much harder to see in the patient who has croup. This would be the area of the larynx here. But because of the inflammation, not enough air is getting in there to give us a good view with the radiograph. We can see the trachea coming into view a little bit lower, but it still looks abnormal. It's very attenuated and difficult to see. It's also smaller in caliber in general. Another thing to notice is that the pharynx, which is this area here, is relatively inflated. That suggests that this child is really trying to breathe in, inflating their pharynx, but none of that air is making it down into the airways beyond. These radiographs are consistent with croup and can be very helpful when the diagnosis is in question. So now that we've diagnosed croup, what are we going to do about it? What is the treatment? Well, many times, in fact most of the times, these are relatively mild illnesses. No specific treatment is going to be necessary. Antibiotics won't help because these are usually viral diseases. If the patient has made it to an emergency room, however, oftentimes treatment is administered. Every child that comes to the emergency room that has significant croup ought to be given a dose of steroids. This is by far the most common thing that's done for children with croup. It's a single dose, and it can be given orally, by IV, directly into the veins, or it can be given intramuscularly. Most commonly, a long-acting agent is given, something that lasts about 36 hours or so. That oftentimes will get the patients over the hump If the steroids aren't acting fast enough, and sometimes they don't because steroids tend to be kind of slow onset medications, and the patient has severe enough symptoms or is in significant respiratory distress, epinephrine can be given. Epinephrine is extremely effective at reducing the edema in the airways, and the best way to give the epinephrine is by inhaling it. It's usually given in a mist or nebulized. One big difference between epinephrine and steroids when being used for croup is that epinephrine is very short-acting. It may only last an hour to a couple of hours. Kids who get epinephrine for croup need to be watched to make sure their symptoms don't come back when it wears off. For kids that have had steroids and epinephrine, and their symptoms still aren't getting better and they're in significant distress, they may need mechanical ventilation. That involves putting a tube beyond the inflamed segment of airway. Occasionally, in the most severe of these cases, a mixture of helium and oxygen is given. This is called heliox, and it's a very lightweight and non-viscous gas. The theory is that the lack of viscosity will allow it to get past the narrow segment of airway. Studies have had mixed results though, but as a last resort, it probably isn't going to do any harm. Other treatments that people have often heard of involve humidified air. There's been lots of studies on this, and most of them have come up short. Humidified air doesn't seem to actually do anything for patients with croup. There's the added drawback that this takes moist equipment in order to happen, and oftentimes moist equipment can harbor bacteria or other pathogens. However, there's probably nothing wrong with running the shower and getting the bathroom all steamed up and having the child sit in there. It can sometimes have a calming effect. So there you have it. Croup is mostly a diagnosis made clinically with the right history and the right physical exam findings. Sometimes other things need to be excluded, and when the diagnosis is in question, an X-ray could be performed. Once the diagnosis is made, there are several treatments, including just observation, or no treatment, a dose of steroids, and for severe cases, epinephrine or mechanical ventilation.